Thank you everybody for joining City and Hackney Enhanced Services Workshop for 25-26. My name is Shazia Shazad. I'm the Senior Primary Care Facilitator for City and Hackney, and today I am joined by
Luis Rivas. I'm the Primary Care Facilitator for City and Hackney.
So, an overview of what we'll be covering. So it will be a brief overview of this year's City and Hackney Enhanced Service contracts. And of course, we'll be talking about the CEG resources available to support you with these contracts, including searches, templates, and documents, and so on. But please note, we're not going to cover the contract service specifications in depth. So you'll need to refer to the IPC website for the specifications and guidance, and of course, contact their team. You can also join us in CEG Tuesdays for further discussion. We haven't started that yet, but it will start soon. And we'll give you a little bit more information about that later on. So first and foremost, before we launch into the contracts, let's talk about the resources because we'll keep referring to them time and again. First and foremost, the CEG searches accessing these. So you must be copying the searches over from the CEG domain. And where can you find our domain? It's below the QOF domain in population reporting. You might not see us, we might be hidden a little bit, so you'll need to click and show more buttons and you'll find the clinical effectiveness group. When you do find that, you'll see the folder within that we've just shown you a screenshot of, the practice support folder for 25-26, and that will always contain our most up-to-date versions of searches. We will mostly be talking about searches that you'll find within folders 1 and 2, LES and public health contracts. And every time that we update our searches, we will let you know via our weekly bulletin. So we've got a link here, and I can paste this in the chat shortly, or you can contact myself or Lewis to request sign up to that. But that's the key form of communication to let you know that the searches have changed. Next slide, please. So a similar thing about accessing our templates and documents, you should access them, and this is the recommended ways to access them via the F12 launch protocol. So for anybody who's not aware of what a launch protocol is, you hit F12 on your keyboard, select one of these protocols, and there's a little screenshot at the side of what the menu looks like. You double click on one of these and it will show you a menu. So we've got two protocols we'll be referring to today. We've got the template protocol, the name of it is there, and we've got the document protocol, and that's launch referral forms choice B1. So this is the recommended way to access our templates and documents because there is a glitch within EMIS. If you search or if you use something that you've accessed recently, there's a chance it may be outdated. So we always recommend that you are using our F12 protocols to access our resources. If you're unsure of how to do this, there are instructions available on our website. Again, the link is within the slides. However, you can go onto our resources section of our website or contact one of us and we can send you those instructions. Every user needs to do it within the practice, but they only need to do it once, and it doesn't matter whichever computer they move from or move to, it will always show up. And then just a reminder that all of our templates and documents, we prefix them with RP to indicate that we have published them, and the RP stands for Resource Publisher. Next, please. So, without much ado, we'll go straight into the contract, starting with the Mental Health Alliance. So the aim is to promote regular reviews and provide support for patients with mental health conditions or those on antipsychotics. The key elements here, you've got depression reviews for patients on the depression register, SMI reviews for those on the SMI register, a similar review for those who are not on the SMI register but may be on antipsychotics for other reasons. You've got the recording of neuroleptic depot injections, ADHD reviews, and a sixth element there, which is care plans for these patients. Next slide, please. So depression reviews, no change. So it's essentially a review for those on the active depression register. So they may be age 16 plus, they've got a diagnosis of depression, and they're actively on antidepressant medication within the last 6 months. So you need to provide them with an annual review in a financial year, and that review consists of 7 elements. So you've got 3 of the elements that must be provided within the last 24 months, which is an offer of talking therapy, an offer of social prescribing, and signposting, giving them the emotional wellbeing leaflet. So those activities can happen in the last 2 years. Then you've got the depression review itself with the clinician, and that will include the medication review. They'll be discussing smoking status and alcohol status, and the target for this is 36%. Next slide, please. So here's the template to use. So time and again, we will be referring you back to the LTC template. The LTC template will contain a page for each LTC that the patient has. So if they are asthmatic, they're diabetic, they have depression, you will see these pages pages appear on the left-hand side. So this is a snapshot of the depression review page, and it has a visibility rule, as I said. So if the patient has a code of depression, and the latest code is that it's not resolved, you'll be able to see this page for the patient. And you can see on the right there that we guide you through all of the boxes you need to tick, the depression review, the smoking status, alcohol status, and so on in that menu. So we get asked this time and again, so we have included it here today for your information, that decline codes are available for various elements: smoking, talking therapies, social prescribing, alcohol, and medication review. These codes are available and within the template. Next page, please. So element 2, SMI reviews, again, no change. So it's to provide patients who are on the SMI register not coded as in remission with a full annual physical health check and medication review. It consists of 9 elements. I won't read through them all, but none of this has changed, and you've got a target of 80%. The other indicator that I've indicated below, this doesn't affect the review, but it's an opportunity to get additional bonus payment. It's to create care plans for these patients. Now, QOF will mandate that you must do a care plan for all of your SMI patients. However, they don't specify what form it needs to be in. They just say you must document a care plan in the record. However, if you were to create this care plan on the Patient Knows Best platform, you will attract a £20 bonus payment. If the patient declines Patient Knows Best care plan, you can use the paper care plan. There is a document available. However, unlike last year, this is the only change. There's no payment attached to this. Yes, the slides will be shared. Next, please. And so here is the template to use. Again, we're back to the LTC template, and this time we're on the SMI review tab. There is a visibility rule. It will be looking for the SMI codes as long as the latest code is not in remission. And what we've highlighted on the right-hand side there is the coding of the care plans. So QOF will just, like I said, they want a documented care plan within the record. However, to identify whether it's a PKB or a paper care plan, to look at those bonus payments, we've given you specific codes for this. So you'll need to code that activity using this template. And again, just going back to the declines, because we're asked year on year, decline codes are available for every aspect within, including the nutritional status and physical activity that wasn't there previously. You've got decline codes for all of these. And every time we mention decline codes, obviously we don't want to encourage you to use them, but unfortunately in practices, sometimes you do need to have that option available. So just to make you aware, those are there and they are on the template. Next slide, please. Now for the patients who are on antipsychotics but are not on the SMI register, it is an identical review for them. It excludes patients who are on the LD registers, SMI of course, dementia and palliative care registers. The health check is exactly the same with the 9 elements and the target is 73%. And then we've got a similar story with a care plan. So you can create a care plan for them. If it's on PKB, it's paid. If it's not on PKB, it's not paid. There's no target for that. It's just paid on activity for both SMI and antipsychotics. Next slide, please. Here's the template to use. So it is, of course, the LTC template with a tab marked antipsychotic review. And again, that just shows you all of the boxes that you need to tick. The template page will guide you through. And as with the SMI contract, you've got the declines for each element of this review. Next slide, please. Neuroleptic depots. So this is really to ensure that you get paid for the work that you're already doing. So if you're administering a depot injection to a patient, you get paid £75 per patient per quarter. And so you can code that using the LTC template, and either the SMI review page or the antipsychotic non-SMI review page, you've got this little box there for depot monitoring. So you want to really tick, we've highlighted, it was really to highlight the section, but the double star in the middle, injectable neuroleptic given, is the box that you'll want to tick for this. Next tab. Right, now onto the other element, the ADHD reviews. So this is eligible patients who are children and adults. And what you'll be doing is for patients who are with or patients who have an ADHD diagnosis and are on a medication, you can give them an annual health check, and that includes a medication review. It's an activity-based payment, and the payment has been changed this year. It's £40 per review up to the borough cap, and you'll have your individual practice caps within. You are back again on the LTC City and Hackney template, and there is a tab for ADHD review. However, if you're reviewing a child, you can use the LTC Children's template to code the same activity. Next slide, please. So the searches, you should have mental health version 2 of the searches available to you now. And all of our searches will follow the same format. The 00 payment indicators folder will have all of the payment indicators so you can monitor your activity. Then we'll have our support and recall and so on. The reason why I've highlighted the support and recall folder here is that we've had a change this year. Previously, you had separate folders for appointment reporting, for missing one activity, or for review incomplete. And what we've done this year is we've grouped it by LTC, so SMI, antipsychotics, depression, and you can see within at the top, you've got a very generic everybody who's got an incomplete review and a line report to tell you exactly what's missing. That second one will say they've got an incomplete review, but actually they've got an appointment booked, so you can do some opportunistic activity. And again, you've got the line report to tell you what's missing. Then below that, you've got searches 1 to 9 will tell you they're just missing one thing. Do this one thing, you've achieved the indicator. And then below, search 10 will say they're missing their bloods, and search 11 is theoretically everything that you can do on the telephone. And then for that last one, if you were aiming to complete the care plan using PKB or a paper document, you've got that search there highlighting where they're missing that activity, which will obviously help you with QOF as well. Next slide, please. Don't forget, now there are payable activities within, but there are value-added activities. So patients, SMI patients who have poor diet or poor exercise, they've got core sports available to them as a service. So make sure that you're referring to them. And you can see on the bottom right here, we've got the protocol launcher, we've gone into the mental health submenu, and you can see that the core sports form is available right there. But additionally, patients with LTCs, particularly uncontrolled LTCs, can be referred to talking therapies for further support. So we can show you there on the top right, you've got a search that highlights the patients with uncontrolled diabetes without an offer of talking therapies in the last 24 months. So we help you to see these groups, and you can obviously refer them for further support. Okay, next slide, please. Now on to end of life. I'm going to hand over to Lewis.
Right, so end of life is one of those contracts that no change at all. We're going to do a recap. So the aim is to improve the quality of end-of-life care and enable patients to die in their preferred place of death where possible. Now, patients need to be added to this register. So the code to use is anticipatory palliative care. And that forms the register, and it is done basically. The clinicians, what they need to do is, if they determine that a patient is likely to die within the next 12 months, then they can be added to that register, and they can be added anytime throughout the year. So for example, you might get a patient in March of 2026 added to that register, then they'll be eligible for this year's enhanced service and in future enhanced services until they're no longer around. So what are the components of the completed template? There are 4 elements. So there's the new or reviewed urgent care plan, resuscitation discussion, recorded preferred place of death, preferred place of care. And this contract does have needs minimum caps, which you can find on your dashboard. So once you begin getting those dashboards, that's a place to have a look for those, and they're defined by the IPC and obviously provided by the dashboards for you by us. So now the one thing to note that in terms of KPI, 40% of the contract value is based on achieving 62% of patients with a preferred place of death achieving their preferred place of death. Right, so just to show you the template is fairly straightforward. We've highlighted all the different components for the completed template. So you can see in the first section there of the second page, urgent care plan, you can tick that, or if or you can do a review. But another element is that if the urgent plan is declined, then that also is valid. And as you can see, all 3 elements are a start. So you tick any of those, and that meets the terms of that. And there, under care discuss, you have all the other 3 elements: resuscitation, preferred place of care, and preferred place of death. And right at the bottom, we have actual place of death. So moving on to the searches. Well, we're showing here is just the payment indicator searches. So just view down here, we provided you a current list showing your ACP register and also for information, your payment accounts, so you can compare those against your targets. And we've always reported the patient died and preferred place of death, but this year we've added an additional search so that you can check your performance according to patients achieving the dying in the actual in the preferred place of death. So as you can see, it's very important to code both preferred place of death and actual place of death.
And just to add, that search, previously you can only see that activity in the dashboard, but it was an important KPI. So that's why we've created this search, so you don't need to wait for the dashboard to come out. You can see how you're doing immediately. Right,
so the additional searches for support, so that identify missing activity. There's a search where you can see patients in the QOF palliative care register, but they're not on the APC register. Now, not all those patients will belong in that register, but it's just they're provided in case you need to increase your register to meet your cap. And yeah, and there's a search to identify patients who have died without place of death recorded. Moving on to wound care. Wound care, another contract with no changes. So recap payment indicators. So this is incidences or activity of wound care performed in primary care for patients who attended A&E or had an inpatient procedure. Now this excludes minor surgery, so those cannot be claimed for, and effectively by adding the post-operative wound care code, you're claiming for activities. So make sure that this is, or that it's available for you to claim. Now the payment rate is for weekdays 12.16 and for weekends is 20.27, and these are approximate. So look at the template. This is very straightforward. Again, so you have the post-operative wound care management generated from practice, from secondary care done by practice. I read that out because there is a code called post-operative wound care that it's not a qualified code. So just make sure it's this code and you use a template. And another element for this is to record the reason for wound care or type of wound and removal of suture and clips. So here we provided both the payment indicator support searches. So at the top payments, there are searches provided showing you activity for weekend and weekday. And then at the bottom here for the support searches, again, mostly for info, I just want to highlight the searches right at the bottom here that are where you have a non-less compliant a POWC code. So you need to review that. There's a line report so that you can view that. I was saying earlier, there is a code that some people put in. If you don't convert that into the correct code, then you will not be getting paid for that activity. We won't be able to pick it up. And then also there's a search right at the bottom there that's codes that indicate wound care missing. So this would be wound care types that are eligible or activity for wound care. And so have a look through that. There's again a line report that shows you patient level and all the different components that. And so if you can identify that some of that activity is post-operative wound care, then use the template to record activity. So moving on to phlebotomy, again another contract that has no changes. The only real change for this is the way you're getting paid for. I'm not going to go through that, but have a look at what the IPC have said about this and how they will be paid you. However, it is still important for you to code correctly. So these are the main codes on the template. It's just blood sample taken, glucose tolerance test, and then there's also unsuccessful phlebotomy. So record that because it is reported on the in the dashboard. And going through searches, as you can see, again, it's very straightforward. They shows you patients with a phlebotomy and the aggregate reports. And the aggregate reports, they do have the problem that they do not differentiate between activity that they're picking up that may have been duplicated or have other issues. So to help with that, so that for data quality purposes, we have provided in the support searches, this search has been highlighted. There are patients with more than one blood sample taken on same day. So have a look if you have any patients in there. Have a look through the records and see if the activity was as appropriate. It's possible that patient may have had activity more than once on the same day, but please review. So over to Chesia for teledermatology.
Thank you. Next slide, please. Thank you. So teledermatology, there's no real change. However, there is a change to the process by which you are referring patients. So the aim is to improve access to specialist routine diagnoses and treatment plans for skin disorders whilst managing them in primary care. The KPIs and targets for this. So there's only one real KPI, which is ensuring that your rejection rate remains below 15%, and the IPC will contact you if they spot any issues with this. But there are no targets. You're paid per activity, and that's £15.90 when I last checked. So the real change is the change to the process of referral. Previously, you were taking those photographs, you were completing our template, you were completing the document, and you were sending that all via ERS. Now you've got the fancy new Isla teledermatology platform, and so you'll be using that to create the bulk of your referral. There are a couple of supporting documents that we provide. If you're doing a routine referral and you've done everything on Isla, you're generating the teledermatology referral supporting information document, and that will just gather additional information about the patient that Isla cannot pull out of EMIS, such as medication, demographics, and so on. And that will accompany the Isla referral and photographs on ERS. If it's an urgent referral, you'll be using the Isla Pan-London Urgent Suspected Skin Cancer Referral Form, and that's a modification of the current USC cancer referral form, but certain sections do not need to be completed. So that would accompany your Isla referral. And if you want to give the patient leaflet to the patient, we do also host that, and that's called the Teledermatology Service Leaflet, Patient Leaflet. Okay, next slide, please. So proactive care, home visiting, one of the big ones. So they're very, very small changes to this one. So the aim of the contract, first and foremost, is to identify and provide proactive care to patients who are housebound or temporarily housebound and would therefore be at risk of their health deteriorating. So there are various key elements. So you want to achieve your payable register, and you'll be pleased to know that there's only a single register this year. You don't have your minimum and maximum, you just have your achieve this target. What makes a patient payable? They need a minimum of 2 visits in a year. They can have more, but no less than that. And one visit can be done by a pharmacist, but this is predominantly a GP-led contract. So it must all be GPs unless the pharmacist goes out to do one medication review. They need a holistic needs assessment done in year. And as part of that, you should be doing and reviewing the Rockwood frailty diagnosis. So that's one of the things I've highlighted below there. That's the other small change. Make sure that you have reviewed that year on year. You also need the urgent care plan to be reviewed. So it needs to be done on the same day of at least one visit. Once you've achieved your payable register, you also need to make sure that you've achieved a 4-visit average across the payable register. So each patient needs a minimum of 2 visits, but that by itself is not enough. So some patients may have 2, some patients may have 8, but at the end of the year, the total number of visits divided by 4 should be equal to your payable register. So that's for 90% of the contract payment. However, you've got an additional 10% divided amongst the 3 KPIs. You've got flu vaccination to be administered or declined in year, 85% target. You've got pneumococcal vaccination to have administered ever to the patient, if not administered, offered, and declined in year. Sorry, not offered and declined as codes for you to tick, but you should be offering it. If they take it up, great. If not, they need to have declined it in year, 76% target, and the medication review to happen in year, or structured medication review as appropriate, 95% target. Next, please. So none of this is actually new for this year. It's the same as last year, but just a reminder about the frailty. The commissioners want you to be coding Rockwood frailty diagnosis. So only the Rockwood codes are picked up for this contract. And at the bottom there, I've just highlighted the quirk that if you code the Rockwood frailty score of 9, it's picked up as terminally ill and it's not picked up by QOF as an indicator of frailty. So you'll want to code severe frailty alongside that. So the commissioners would like for you to code not only the Rockwood, but the comparator, the generic mild, moderate, severe. So we give you a section on the template to code that, and we'll demonstrate that in a second. Next slide, please. So here's the template to use. It's RP Proactive Care City in Hackney, and that's just a snapshot of the Proactive Care Home Visiting page. At the top there, you can see how to add the patient. You can see the requirements to meet the contract, and below you'll find the rest of the review down there. Keep going, please. Then you've got the frailty tab on the same template. So this goes back to what I was saying a moment ago. Within the diagnosing frailty section, you can see you can code the Rockwood clinical frailty scale diagnosis there. And then just below that, you've got the equivalent. So we do give you a conversion if it's Rockwood 4, if it's Rockwood 5 to 6, or if it's Rockwood 7, we've given you conversion of mild, moderate, and severe frailty below. Please ensure that you're coding those on the same day. Next slide, please. So the searches, you've currently got version 1, version 2 is coming out imminently, but they all follow the same standard again. Payment indicators within that first folder, we show you your payable register, and again, you need to meet your payable register requirement to be in with a chance to achieve your 90% of the contract payment. Then below, we show you the KPIs, so flu, pneumococcal, and medication review is all below. Next, please. So we've got a lot of support searches for this contract, and this is just showing you the recall searches. So we help you to identify those patients who haven't had any reviews in year, those who've had 1 review in year, and those who had 0 visits, 1 visit, and 2 visits in year. So each patient needs a minimum of 2 visits, but you would ideally be reviewing them quarterly, in which case these searches will help you to identify where in the process those patients are. At the top, you'll see we've marked priority recall. Those with 0 visits, never visited. Those will be patients who are new to the contract this year. So that will help you to identify them and start those first visits for them. The others within that set will be those who have rolled on from a previous year. With those who've had 1 visit in year, we try to tell you exactly what's missing so that the next time you go to visit them with that second visit, you can make them payable at that point. So you've got list reports for these as well, telling you exactly what's missing, who reviewed them last time, do they have an appointment upcoming, so you can use this to recall and plan your visits. Next, please. Now, on to proactive care, the practice-based element. There's no changes to this. So again, it's the practice-based equivalent of the proactive care home visiting service. These patients are complex. They may be frequent attenders. So you are paid to review them within the practice, provide them with a longer appointment or multiple appointments. So patients can be payable under 2 tiers, and it's up to the individual practice budget cap. So we don't say you must do this many in tier 1 and this many in tier 2. You just work that out based on the amount of budget that you've got available to you. So in tier 1, so for both of these tier 1 and tier 2, half of the reviews need to be done by a GP. So for tier 1, the patient needs 2 reviews, and at least 1 of those must be done by a GP. One of those reviews will need a same-day care plan review on urgent care plan. You'll need a holistic needs assessment in financial year, and again, you'll need that Rockwood frailty diagnosis. And then for tier 2, 4 reviews, 2 to be done by a GP. If the GP does a home visit, that counts as 2 reviews. Again, 1 review with the same-day care plan review, holistic needs assessment in year, and the Rockwood frailty diagnosis if they're over 65. Next, please. The searches, these are available to you or will be available to you very, very shortly. But essentially they are the same as last year. In the indicators folder, you've got tier 1 and tier 2 payable. Next slide, please. And then you've got the support and recall. And again, we try to make sure that you can see exactly what's going on. As the patient had 0 reviews, 1 review, was it done by a GP? Was it not done by a GP? What exactly is missing? I actually think this is an old screenshot that I needed to update. You've got a lot more available to you now when you look in those folders. Next, please. LTC core. So the aim of the contract, it's for earlier identification of and improved management of existing and not yet discovered LTCs with the intention to improve health outcomes for patients. So without going into too much detail, because these indicators have remained static for multiple years, it consists of annual patient reviews, such as those who are on the diabetes register, sickle cell register, who are at risk of diabetes or CVD. You want to be improving control of LTCs, such as hypertension. You want to be maintaining control of their blood pressure. You want to improve your prescribing for key groups, and you want to be identifying LTCs earlier, such as with the pulse rhythm. You're screening for atrial fibrillation, hoping to identify that as early as possible. Previously, it was 27 indicators. It's now 28 with the new continuous glucose monitoring indicator. And just a reminder that the carer indicator, which has had no target for years, now does have a target. And then we've got the health inequalities element, and those indicators remain the same as in previous years, but we do provide support for those. Next slide, please. So the search for the continuous glucose monitoring indicator is not out just yet. The syntax is undergoing refinement, and you will also get detailed guidance from the commissioners on this. But just a reminder of what it is within the indicators is that it's continuous glucose monitoring for type 1 diabetics. You want to be highlighting the availability of continuous glucose monitoring that is available for them under secondary care. If they are under a specialist, you want to be confirming that on the patient record with the patient, and also again approaching that discussion with them. But if they are not under a specialist, you want to have a very involved discussion with them and be connecting them to secondary care to ensure that they've got a route to obtain CGM. So like I said, further guidance to come. You currently have LTC Core version 2 available to you, and it's marked as interim just because of the absence of this indicator, but the targets are all within now. So next slide, please. So we're back to the LTC Core template, and just a reminder, because the LTC Core contract covers so many domains, you've got at risk, you've got CKD, you've got diabetes, you've got hypertension. You will be coming back time and again to the LTC template. It's got the visibility rules, so whichever one the LTCs the patient is has, you will find the tabs there for you to complete the reviews for them. And just a reminder that some of these indicators do have exceptions within. So we've highlighted the QOF PCAs tab because you'll want to be following those for that. Next slide, please. The searches. So we haven't changed anything with the searches this year. You've got a lot of support available to you, but just to go through, you've got the indicators. So that's to monitor your achievement, and we've added the targets in there, as you can see. Then we've got, next slide, please. We've got the recall folder. So the recall folder is the inverse of the indicators folder. It's everybody who was eligible within the denominator of that search, but has not been exception reported for anything. So this is essentially your cohort that you need to work on. So we've got the generic, this is your recall folder, but then we've also got on the left there the appointment recall folder, and it follows what we've got in other contracts, which is where the patient has an appointment, they haven't met the indicator, so it gives you the opportunity to do some opportunistic work with them. Then you've got the support folder on the left here, so you can see you've got some very detailed searches within to help you focus on specific disease areas. Next slide, please. And here's an example of one of them. So the CKD indicator, some practices do struggle with this, and this is about diabetic patients who have evidence of CKD but have not yet been coded with CKD or had the CKD ruled out by testing. So the searches within here will tell you exactly why the patient has been picked up as having evidence of CKD, and you can go through that to help increase your achievement. And just a reminder that CKD is classified as and the clinicians can correct me on this one. I believe it's G1A2 or G2A1 and above. So G1A1 is not accepted because that is basically everybody, is what I've been told, and it's not clinically significant, but you'll be looking at G2A1 and G1A2 and above as a CKD diagnosis. And we're looking for those specific codes as well, because with QOF you can have a generic CKD stage 3, CKD stage 4, but it doesn't comment on both the EGFR and the ACR, whereas the G1A1, G1A2, and so on, that does comment on both of those values. So that's why we're looking for that coding. Next slide, please. Then we've got the health inequality searches. Again, these remain unchanged, but they sit within folder 6. And the way to use these, you've got the baseline folders. So if you're remaining on focusing on the indicators that have been chosen by the commissioners, then you'll be looking in those folders. You'll be running it with a relative run date of the 1st of April of this year, 2025. Then you've got the financial year searches that will support you in seeing how you're doing, monitoring your progress. Next slide, please. Early onset type 2 diabetes. So there's no change with this one. You're improving the care of patients with a type 2 diabetes diagnosis at an early age. So those aged 18 to 39. Now I've put an asterisk next to 39 because that should be the upper age limit. However, some patients were eligible at the start of the year. They were on the very cusp of 39 and 40, and they have or will turn 40 in year. So just to make you aware that those patients are still eligible. So if you see that tab come up on the LTC template and you think, hold on, this patient is 40, is that correct? It is correct. So you've got lots of elements within this review, but it's recommended activities. So you would be ensuring that care processes are complete. You'll be considering the classification of diabetes type. Is it genuinely type 2? Could it be type 1 or another classification? You'll be offering preconception advice to all women. You'll be optimizing glycemic control and so on, everything listed there. And there's no, I don't want to say a target, it's payment per review. And I believe it's in the range of £50 or so, 52 or above, IPC can confirm. And it's up to a maximum practice cap. Next slide, please. Now here's another slide that I should have swapped out. I'm showing you the diabetes review page, and that will show you this is the only box that you need to tick to evidence that you've done the review. You are recommended and you need to do the other activities, but for payment purposes, we're looking out for this double starred box. The reason I say I should have updated this slide is because there is an actual dedicated early onset type 2 diabetes tab that is available that will guide you and support you with these reviews, with these extended consultations, I should say. Next slide, please. LTC cancer. So we've got various elements, the same, such as fast track referral safety netting. So any patient you've referred under fast track or urgent suspected cancer, I should say, you know exactly what the outcome was. You've got the, thank you, Amaya, £52. I did think it was that for early onset consultations. We've got the Time to Talk Cancer extended consultation. So these are patients with an existing diagnosis of cancer. You want to make sure that you're giving them time to discuss all of their concerns. We've put prostate cancer within here because it falls under the umbrella of cancer, but it's about those patients who have got a stable diagnosis of prostate cancer, and now they have been referred to you by secondary care for monitoring of their PSA. And then you've got targeted bowel cancer screening. So this builds on the work that was done last year where the Community Africa Network were reaching out to your patients to improve uptake. The searches are not yet in the folder that you've got out there, but they will be coming soon. Next slide, please. So here's a snapshot of the searches. And this is, I've left this folder as per last year's folder because this is what it will be when it's finalized. But you can see you've got the Time to Talk Cancer folder, and you can see on the top right, you've got all of the indicators within, and then below you've got the support searches. So all of those patients who are registered with a fast track referral, you haven't coded whether they've been seen or DNA'd. And then you've got those patients who were referred with a fast track referral. They may have left and died, so it's there for you to monitor, but we took them out of your main support search because we recognize that you can't always do anything for those to close the loop, but they are there for you to be aware of. Then you've got the code, the main search below, which is for all of these patients, those who have no code for seen or DNA'd. And then an information search below just showing you who's been seen. Next slide, please. Time to talk cancer. So again, you've got this is really for patients on your cancer register, your QoF cancer register, and we show you who you've offered the consultations to. So offered or declined constitutes an offer, and those who have attended, and then you can just see which of your staff groups are delivering those. Next slide, please. Prostate cancer, so this sits outside of the main cancer suite. You've got in the indicators folder, it will give you that top level. This is the register. These are the patients discharged to us from secondary care. There is a template for this. This is on the fast track safety netting. I want to say it's on that template there. And essentially you want to be putting them on your practice register by following that template. There are two activities for this. Ideally, we want the PSA. You're monitoring their PSA. The hospital would have discharged the patient to you with an individualized threshold, and you would be monitoring the patient for that. However, if you don't manage to get them in, you will get paid for making 3 attempts. And so you can see exactly what's going on here. If the patient has been newly discharged to you in year, you should be offering them a welcome appointment and completing a holistic needs assessment for them if possible. So again, you can see that at the bottom there. Next slide, please. Okay, back to Lewis for LTC children.
Right, so going to go through LTC children. Key elements are that they have an asthma care plan reviewed annually. Again, this is one of those countries that again, no changes, all the targets are the same as well. So 87% for that. And then patients with asthma or viral induced wheeze, they get followed up in A&E, 35%. And annual review for patients on diabetes, epilepsy, sickle cell registers, and that's 70%. So the template, we're not going to go through the entire template, just going to highlight this particular part of the template, because for A&E attendance for children with VIW or asthma, there are some practices still, or a lot of practice with 0 activity or just 1 or 2. So it appears that it's not well recorded, and we think that if it's not well recorded, it could be because practices just don't understand the process. So just going to go through the template so you understand that. So once you receive a discharge summary from the hospital, if whatever it is, you take the discharge and put the date on there. And if it happens to be for asthma viral induced wheeze, then you would code them here, and then would indicate tick this box for follow-up. Now, the way this works is that if you look in terms of time, if the patient went to A&E, let's say 5 days ago, you received the discharge summary yesterday, but you're only dealing with it today, and you tick this box, the follow-up 2 to 3 days box, then that's what starts the clock ticking for the 3 days that you have to deal with this. So at that point, once you tick that and save it to the patient record, you would contact your clinician, whichever way you want, and then that clinician would then have 3 days from that point that was recorded to do the review. And as long as they can do by telephone, by the way, or bring the patient in. And as long as they tick this box, follow-up respiratory assessment, there's a separate one for each. There's a separate page for viral induced wheeze and asthma. As long as they tick that box, then that closes the loop. And that's it on that. So looking at searches, we've got, so this is support and recall searches. Just highlighted the big highlight here, just on patients who are either diabetic, epilepsy, or sickle cell. So these are patients who still have not had the annual care contact. I noticed that a lot of practices, as the year goes through, they may not have this done. It could be because you've got a diary entry set up for the end of the year. But anyway, have a look and see if you do that, or whether you need to call them in. Now, the main searches for the viral induced wheeze and the asthmatic children attending A&E are these two. So these are basically where you're missing the review. So the practice has coded that code that was shown in you earlier. They've ticked this box, follow up in 2 or 3 days, but this code is missing, that one there. So you need to act on that. Have a look. If you miss the, if you miss the window, then it's too late. But it could be that the activity was done and it's just not coded. And then right at the bottom, you've got patients where you've coded the discharge letter, but you haven't coded follow-up. And that could be okay, because it could be that the discharge was nothing related with viral induced or asthma, in which case you ignore it. But if it is relevant, then have a look and see if you missed the window or not. If not, then obviously contact the code as appropriate and contact your clinician. So moving on to time to talk. So time to talk, the aim of this contract is to provide the extended consultation for payments for patients with multiple or complex long-term conditions or who have a care status to ensure that patients receive support. So the eligibility is also, so it'll be 2 or more patients with 2 or more LTCs, and then you have single patients in single registers, so they're a carer or they just long COVID or the hemoglobinopathy, or they have the LTC code, multiple LTC code. Now, this multiple LTC code can be added in by clinicians if they see fit. So if they have some patients that they would like to review for whatever reason, then they can add the code. Sometimes they do it because there's a patient on, let's say, on diabetes, and let's say on osteoporosis, which is not one of the main LTCs that the search looks for. Then they deem them to need the extended consultation. So it's entirely up to the discretion of the clinician. Now, the extended consultation is a 30-minute consultation. There's minimum, maximum targets. The minimum one is very important because every single practice should achieve minimum, because otherwise there's a penalty that's applied to the entire pot of money for the whole of City and Hackney. So if you look at this in a sort of way at the beginning of the year, the rate would be that you would pay for the extended consultations is £50. But at the beginning of the year, nobody's achieved the minimum, so effectively £0 rate. And then at the end of the year, you would achieve, if you achieve the minimum payment of all the practices, then you would get paid the £50 per consultation. So if any practice misses the minimum target at the end of the year, then that would reduce it. So for example, you could get like £47 per extended consultation, and that would be applied to every single practice in City and Hackney, so they would lose a little bit of money if that minimum wasn't achieved. Now, the searches are very straightforward. Again, just a simple recall search. And the only thing that we've done here is just provide 2 additional searches that are just to help you that perhaps call patients that might be more in need of this intervention. This extended consultation. So patients with 3 or more LTCs, or patients who are carers, but have not had an offer of support yet.
Lewis, if you could just
Yeah.
go back a slide, I just wanted to come
Yeah.
back in on that one. So we're just highlighting groups here. It's not necessarily that they may be more in need of this intervention, but I just wanted to point out there at the bottom one, it goes back to your question, AJ. What actions are needed to achieve the targets for carers. So that goes back to LTC core with the carers indicator. It's that the patients have been identified as carers, and there's no target on that. You have no idea how many of those patients will be carers, but you're proactively identifying them. Once you've identified them, you want to offer them an assessment of their needs. You want to be offering them a referral to the carers centre to make sure that they are properly cared for. So this is another way that you can achieve that indicator here, carers without offer of support. So you can highlight them here, call them in for an extended consultation, and make sure that you are also offering them a referral. And in order to code that activity, you've got the carers tab on the LTC core template, and you can tick the box that says assessment of needs offered to carer or referral offered to carer. Both of them are fine. Thank you.
Right, so gonna go through early years now. So the main components of the early years are 3 maternity parts. So preconception advice, maternity first contact, and 6-month health and well-being check. So this is effectively a postnatal exam then after 6 months after delivery, and specialist level for children. So starting with targeted preconception, the eligibility, this would be women aged 20 to 45 with an LTC, or who have a hemoglobinopathy or a miscarriage in the last 6 months. And also to note that any activity that done under the early onset type 2 diabetes that qualifies for this would it would get paid under this. And just to remind people that if you meet your target for early onset type 2 diabetes, then this wouldn't pay anything, but because effectively you'll be 100% of that. But if you underachieved on early onset type 2 diabetes, then any patients that remain that have met the terms of the targeted preconception exam, then they would be paid under this. So it's £40 per review.
I'm just going to correct something there, Lewis. I think you mixed the word. If you've overachieved on your early onset, not if you've underachieved. If you've overachieved on your early onset type 2 diabetes, you've over-delivered. Those patients can also be paid, if not under early onset, then under early years targeted preconception.
All right, sorry. So key elements. So obviously planning to start a family, that needs to be coded. Once you've had the discussion, if they are planning to start a family, that's one of the elements. And then you would, the practice would then do the preconception advice, and the validation is effectively, there's other elements, but as a minimum, they would need the BMI recorded either on the day of exam or in the last 28 days prior to the exam. So looking at searches, so support and recall searches, just wanted to highlight just this one, the miscarriage. So patients miscarried in the last 6 months. Although we're providing a lineup of our book, it is good to consider calling these patients because of sensitivity of the issue. But otherwise, you have here at the bottom, you have the main recalls set of searches, and you do have the AccuBook report there that you can use for recalling these patients. And these are intended for a leaflet that exists on CG's IMIS. It's effectively to invite, but if you've seen that, then anyway, I'm not going to go through that. It's just that it's available. Yeah. So for first presentation, so moving on to first presentation, so the exam with validation, you get paid £40 if you do all the elements of validation, which are BMI from 28 days before, done 28 days before or on the day of exam. You have social risk and obstetric risk done on the exam day or up to 5 days after. And then the antenatal referral done on exam date or up to 14 days after.
And just to point out, sorry, with the antenatal referral, it does also accept self-referrals. So you may actually just be signposting the patient to do the referral themselves, tick the self-referral box if they've done that or are planning to do that.
Yeah. Okay. So again, the first fairly straightforward recall search. So first contact, missing activity. That activity missing could be just the first contact, but it'll also detail if you're missing any of the other elements. So the 6-month health and well-being check. The eligibility for this is women aged 16 to 50 years with a vulnerability, and we've listed all the vulnerabilities here. Just to pick a few out, patients that have potential ever disability, stillbirth in the last 12 months, and child removed after birth. So just highlighting those. I'll come back to those in a minute. So what are the key elements? So 6-month health a check, you get paid £40 for a validated exam. The validation is basically either so it's BMI and BP that on the exam date or 20 days prior to the exam, and contraception counseling, preconception advice, and depression screening on the same day of the exam. Now, the search and recall searches, they've been separate. We've separated them according to a top-level search eligible for research, which is this one. And the things I wanted to pick out of this one is the sub searches. We've separated delivered, child removed, and stillbirth. And the reason to highlight this child removed and stillbirth is because there's specific letters for that are more sensitive. So when you send the invite to the patient, there is a specific letter you can send, but there's two separate letters on EMIS that cater for that, because obviously they have to be worded in a more sensitive way. And right at the bottom, there's a search that's got 6-month exam done, but no vulnerability is recorded. Now that could just be that it is valid, but you just haven't recorded it. So have a look through. If you have any patients on that, have a look through it. Now, what I wanted to say earlier is just I forgot to say that for recall for 6 months, 6-month health and well-being check, this is done effectively after the woman delivers. It's meant to be done 6 months after, but there's a window. It was allowed is 5 months to 7.5 months after delivery, so it gives you a broader window. The only problem with that is if you do it too early, obviously that won't be picked up as a valid activity, because it could be just normal postnatal. And then if you pick it up after, then obviously we might not pick it up as as valid activity. So just make sure that you go through the recall searches, mate, and follow me in time. So moving on to children, this is also part of early years. So this is now a specialist level. It used to be what we called Universal Partnership Plus, is for children not to 4 years old. So that's under 5 years old, who are on the specialist level register. So that's a health and well-being service specialist level. That's what the exact code is. And then the practice is supposed to have a discussion with the health visits and agree a joint action plan. And for that joint action plan, if it's brand new, it's the first time that the child gets this action plan created, you get paid £64 for that. If they've had the joint action plan created in previous years, in this year it's just been reviewed, then that gets paid £30. But from Q2, I think, of last year, we started a second review started getting paid. So basically, for a new action plan, if you then do a review that's 28 days after the initial action plan, then you get paid for that review. And then if you've done patients who have had a previous action plan in previous years, and this year they had the first review this year, then again, you can do a second review that's 28 days after. That one again pays £30. To support the recall searches, I just wanted to highlight this one. All register code users, basically patients who are still on the UPP register. You might want to recode them as or code them up. You don't need to remove all coding, but just code them up as specialist level. And then just wanted to highlight the two main recall searches with a no action plan. So recall. So these are brand new patients who have never had an action plan. So that's your main recall. And then you have patients who have had an action plan before, but they need a review in this year. So that's your recall search. And then also highlighting a couple of searches that tell you which patients you've done a review on this year. So either an action plan or a review, then need a second review. So now moving on to health checks, NHS health checks, eligibility age 40 to 74, who are not in a CVD register and not on statins already, who have not had a health check in the last 5 years, and who are not in the risk of CVD or diabetes registers. Now, a quick note for that is that it's essential that the QRIS calculation is used for assessment. And the reason I say that is because every year we get a few health checks recorded as done, and the QRIS has never been calculated. So the multiple KPIs on this. Sorry if that's too small for you, I'll read them out. So it's 13.2% NHS health check delivered. So this is at borough level, and this includes health checks done in the last 5 years. Now there's a practice level target, which is 12% NHS delivered. So this one excludes health checks done in the last 5 years. And this goes to inform a minimum target for practices. So also there's 25% for the several populations, Black, African, Caribbean or South Asian population, 52% for male population, 58% for under 50 is the population. And then there's 80% for the risk report. So that's what's on the spec. However, it is expected that, and it's that, desired that every single patient should receive that risk report. It's not that difficult to do, and it's easy to send out because you can email it. I think you can even text it, or you can print it for the patient if you really wanted to. Now, the new targets, and these are health inequalities targets. So 80% target for completed health checks where appropriate lifestyle brief advice was recorded. So this, so it's for current smokers, inactive or moderately inactive patients, and you would use GPAC for this, above healthy weight, BMI for that, and drinking above lower risk levels. So this you would be using audit score.
And just to qualify that, Lewis, so if it's a current smoker, you're offering them smoking cessation. If they are inactive or moderately inactive, you're offering them, exercise on prescription. You're offering them lifestyle interventions there. If they're above a healthy weight, same. They may be eligible for weight management. And if their drinking is above lower risk levels, again, you're offering them support with that.
Yeah. Okay, so moving on to the template. Now, you may have never seen this page, this part of the page. So this is on the main page. So we've added this this last few months. So if you are attempting to do a health check and you see this, it'll come up with this patient is unsuitable for NHS health check, and it'll be due to any of these scores coming up there. I mean, we've added the latest of each one of those. So clearly it's not because of the CVD risk, but it's because of some diabetes risk. They've already been identified, so they'll be being taken care under the at risk of high risk of diabetes. So if that happens, then you need to revert to an at-risk review or book an at-risk review instead. But hopefully none of you ever see this page coming up. It's not a page, it's just a section at the top of the template. So that would be somewhere about here. That's what that would appear. So looking at the first page, health check, right at the top, you would have the record health check completed. And then following that, there's different sections that would help you to record activity that's used for QRIS, some examinations, etc. So not going to go through that. All these are intended to inform the QRIS. Now, once you get to the QRIS calculation, just make sure you calculate it. EMIS still provide the QRIS 2, so you might as well use that. But if you prefer, we've given you QRIS 3 web page, so you can calculate that. But if you do use that, then make sure that you add the score here, and then you add the hard age as well, because hard age is used for the risk in the risk report. And then if the patient is a QRIS 10 or above, then there's a whole series of services for lifestyle interventions that you can use, and they're all listed through there. If the patient is concordant, they don't need any lifestyle interventions, then tick that because it's useful information to have on the record. So searches. Just going to right for the top, there's a few. So missing NHS health check risk reports. So once you run your searches, if you miss the risk report, you've already done the health check. So have a look at that. You can do that after the event because if you haven't done it, because you can send it to the patient and the clinician might want to annotate the reports and contact the patient after, but it's up to you. But you can send it to the patient. It's usually just a summary of the health check. And the main recall search is this one. That's the main recall. And underneath that, you have all these searches all the way down here that are all part of recall. And so if you're stratifying your recalls, then you got low, medium, and high. So perhaps you might want to start with high first and medium, and then move on to the low. But don't forget the no risk. The no risk are where the patient has never had the risk calculated. So that might be hiding patients who are at high risk. And then you have the focus populations that we were talking about just now with all the different targets. And there's a useful search right at the bottom there, kill two birds with one stone, as they say, men age under 50. So that would improve your targets for both of these in one go. And that's what I wanted to say on that. Now, this is also part of the NHS health check, HIV screening. That started, I think, was it a couple of years ago? HIV screening through TQuest. So this is the automatically included in the NHS check blood suite in TQuest. Patients who do not want the test need to actively opt out. So as a clinician, when you got the patient in front of you, you need to go into the NHS blood suite in TQuest and remove the HIV from there if they've opted out. But otherwise, they would have the HIV screen. Okay, moving on to sexual health. Justin.
Thank you. Yeah, next slide, please. So the key elements are, and they are not new to you. So there's the LARC fitting. There's something I want to mention about the LARC fitting, which is that previously, if you were fitting an IUCD or an IUS, it was counted as the same activity. This year, there is a requirement for us to actually identify which of those are being fitted. I believe they attract a different payment. That might be the key driver for the reason behind the coding, but we've had to separate those. So it's very, very important that you're coding this activity on the template because the template contains the correct codes, but the implants remain the same. Then there's LARC removal. It's the same IUCD, IUS, and implants. You've got the STI screening, including the National Chlamydia Screening Program. You want to be offering that to the younger population. And then you've got universal HIV screening for your newly registered patients, age 15-59. So there's nothing new there. Next slide, please. So just a reminder that there is the LARC practice element of the service and there's the inter-practice element of the service. So the way that we identify practice activity is that that's been performed on regular patients of your practice and you have identified and used the correct consultation type, which is face-to-face. So that way we can say this is a regular patient of that practice and it was done in the face-to-face consultation. So we know this was practice activity rather than an enterprise right back. Next slide, please. And then when it's by into practice, again, in the practice, to make this very clear that this is not your activity, you want to be using the code LARC fitted by other healthcare provider. And again, that's on the template. And just a reminder that where hub practices do complete this activity for you, they do send notification letters back, which is where you might be coding that activity from. Next slide, please. A reminder that when you are diagnosing STIs, you need to ensure that you've coded that as activity under the enhanced service. So that code is on the template in multiple places. And also, if there is a positive STI diagnosis, you want to be discussing, encouraging the patient to discuss that with their partner. So there is also an element on the template that you can tick to say that you've discussed partner notification. So just exactly what I said a moment ago, new patients for the universal HIV screening offer, new patients aged 16 to 39 should be offered HIV screening within 3 months. And the National Chlamydia Screening Programme, the sexually active 15 to 24-year-old patients should be offered chlamydia screening. Next slide, please. This is a slide where I should have replaced the searches. We haven't quite released the searches yet, but they do look drastically different from that. And I'll show you a quick screenshot in the chat box. So that's what the payment indicators element is looking like. So that's for sexual health screening. What we've done is we've put it all together so you can see your quarterly and annual activity together. And our support searches have changed a little bit. The condom element of this has gone. So you will no longer see the condom searches within, but if you look at that screenshot, you'll see that's what our support searches are looking like. Next slide, please. And yes, the support searches or the support folder is ever so slightly different now, and I'll just get you a quick screenshot of that. Essentially, it's still searches that cover the same elements, which is that if you've put in an IUCD or an IUS, actually no, this is the new search. If you have inserted an IUCD or IUS and you're using old coding or different codes, we've reiterated the importance of making sure that we know exactly which activity is taking place. So you'll have a support search to help you identify what's going on there. Thank you, Lewis. Then you've got the usual new STI diagnosis, and you haven't put the enhanced service code in, so we don't pick that up as screening done by your practice. And then you've got the STI under enhanced service, but you're missing the partner notification, ignore the duplicate search there, and then you've got your newly registered patients without HIV screening. So in the suite, you already have a version of these searches. There's just 1 or 2 more coming out to you. Next slide, please. Back to you for latent TB. Lewis, you're on mute.
Sorry, eligibility, patients age 16 to 35, no history of TB or LTBI, not previously screened for LTBI in the UK with any of the following risk factors. So identified as flag 4. This list is provided by Public Health, and they may be identifying the patients for various reasons, but they probably include some of the lists that we're going to go through here. So additionally, for eligibility, so patients born in high incidence country, has spent more than 6 months in high incidence country, entered the UK in the last 5 years, or ex-prisoner or alcoholic or drug users that's current or past, or are homeless. So as a very basic thing, the flag 4 list is the main one to do. You do need to try and do all the patients provided in that list. So in terms of payment, so you can do up to 3 invites. Each one pays £2.50. Although there's occasionally a 4th invite that's possible, and that would be on patients who have had a test, but the result was indeterminate, or who booked an appointment but did not turn up. So then you would get invited again, and you get paid for that, regardless of what happens after that. And then for all those patients who have had a GREEGA test done, that's a T-spot TB test, and you get paid £25. And then just make sure that you record the blood sample taken. I know it's getting paid in a different way than through coding, but all this coding is still important. So supports in recall searches. So here the main invitations searches. So those are your main patients. You've not invited them just yet. So 0 invitations. Those that you've invited once, they've not replied or interacted. So you need to invite them again, and those you've invited twice, but you can invite them 1 more time. And then those ones I was talking about, the 4th invite. So they've had 3 invites, but they DNA'd or indeterminate, or have been coded as indeterminate. Now there's a specific search that we've created for indeterminate results. So you find those patients here. So those are patients without follow-up. So you know that these patients were willing to get the test done. So if you have any of those in there, make sure that you invite them because they're likely to go again. And then last of all, there's a provision of ICRA test without the eligibility code. So basically that means that a test has been done, but there's no indication that the patient was eligible. So check through the records because it's quite likely that there's obviously a valid reason for that. You just need to make sure that you find that and code it. Okay, over to you, Chesia.
Thank you, Lewis. So just a reminder of the other resources that are available to you after today's webinar. So we have our weekly e-bulletin. Hopefully you're all signed up for that, but if you haven't had a chance to sign up, then please do let us know and we can do that for you. You can always contact a facilitator. Lewis and I are here for you if you need support via email, if you need support via Teams. We're happy to troubleshoot with you, so just shoot us an email. CEG Tuesdays, as I mentioned earlier, I don't think there's anybody new in the chat today, maybe one or two, but you should all be familiar with our weekly online support space. I'll drop in on Tuesdays from 2 to 2:30 p.m. We haven't yet started this year, but we will be starting imminently, so watch out for that announcement in the bulletin. And in CEG Tuesdays, you're joining the CEG, myself and Lewis, and you're joining members of the IPC team to discuss everything related to our resources and contracts and everything in between. We also make sure to relay important updates to you there, so it really is an important space. You also have the option, or you also have the ability to speak to other practices. Obviously, you're all there from the practices together, so it comes up with really interesting conversations, really worthwhile signing up for. After and shortly, we will be commencing our face-to-face practice facilitation visits. So what we do is we come out to you and we'll do a performance review. We'll say, here are the contracts, take stock of where your performance is at the moment and speak about any quick wins, any idea, any areas of concern or anything that we've identified that we need to discuss with you. The agenda is also informed by the practice, so if you need to troubleshoot anything, if there's anything you were curious about asking, anything you wanted to request, again, we're there to help you with that. And then, of course, we have our dashboard, so for you to be able to monitor your achievements. So they'll be trickling out now, and they'll be monthly or quarterly, depending on the contract. So you can actually look at that and see how are you doing, how are other members of your PCN doing, how are you doing as a borough. Next slide, please.
I'll just say for the dashboards, if you don't have access already, get in touch with us and we'll send you the link on how to access those.
Thank you for joining us. I've just put some links in the chat. Number one is you can sign yourself up for the e-bulletin if you're not already signed up for that. I mentioned earlier about the practice protocols that we've got some how-to guides available, so that's also the link for that is there. And then lastly, but most importantly, please, we do ask that you give us some feedback on the session today so that we know that we've hit the right note, we've provided the right information, and to make sure that our future webinars are useful for you all. So please do take a couple of minutes to fill that out. Thank you very much, and we look forward to supporting you this year.